Hi everybody. Today I am going to be presenting on-site joint reductions. Here is a brief overview. I included a lot of information on this PowerPoint, so I would recommend going through. Even down in the notes section, I have a lot of resources. I wanted this to be something useful for you guys. So there's going to be a little bit more on the PowerPoint than I'll talk about on this video, just for the sake of time for everybody. But moving forward, some advantages to on-site reduction are you're trying to avoid muscle spasm and swelling that can severely limit any delayed attempts at reductions. The longer that a joint is dislocated, the more muscle spasm and swelling that's going to start to develop and get in the way. Also, the patient is going to be in a lot of pain and discomfort as long as it's dislocated. You want to restore vascular flow as quickly as possible. You want to limit articular cartilage injury and skin compromise. And then also it can reduce the need for immediate referral. So if you have a joint that is dislocated and you're able to successfully reduce it, they have good neurovascular, everything's checking out there, then you can wait, till the following day, call doc rather than having to go to the ER that night. Some disadvantages worth mentioning that we can't completely rule out a fracture. When you do our tests, you try to minimize the risk of that being there before reduction, but it can always still happen. Also, you don't have any sort of sedation or medication typically in the athletic training setup, so the patient is going to be in some increased pain and discomfort, usually while you're trying to reduce, and then legal liability is always something to consider. All of these red flags are things that we should already know. Obviously, if you have signs of pelvic or femur fracture, large hemorrhaging, open fractures, arterial injury, nerve injury, these are all things that you're going to want to send them to the ER for. You also should be aware that compartment syndrome may develop later, so repeat assessments are important. I'm going to move through some of these general considerations real quick. Again, there's more information on these slides than I really need to go into detail on right now. The gist of this, make sure you know your Practice Act and make sure you talk with your supervising physician and you're doing something that they're comfortable with and that the patient has consented to you pulling on their dislocated joints. This is all pretty standard as well. You're going to be doing your history, you're going to be doing your neurovascular exam, ruling out for fracture, all of those things before you try any sort of reduction. Post-reduction, useful acronym here are check the facts. So function, arterial blood supply, capillary refill, temperature, and sensation, and immobilize and refer. There are some considerations for special populations. What we will most likely run into in the athletic training specific or the typical athletic training population would be to be aware that some like open physies don't close until about 16 to 22 years in some patients. So that will affect the rest of the stuff. We probably won't have to deal with as much, just useful information to know. All right, so getting into the fun stuff now. So some joint-specific techniques and recommendations. So talking first about the glenohumeral joint. This one's probably the most fun in my opinion. So your anterior dislocation is going to be the most common occurrence. Any sort of posterior or inferior dislocation, you're not going to want to try to reduce on site. We don't have very many good techniques for it. There's going to be more tissue in a position. There's more likely going to be a fracture. So those you're going to want to refer. But if you have that anterior dislocation, that's when we can go ahead and try and attempt there. I included the Boss-Halzak-Matter maneuver, also called the Davos technique. This is a self-reduction technique. So especially if you are feeling uncomfortable, but you want to help, you can talk the patient through this. They are doing it themselves as long as they feel comfortable doing so. So in this technique, the patient is going to be seated. They're grasping the wrist of the affected side with their contralateral hand around their raised knee, and then leaning backwards with that head tilted back as well. If that's still not getting it completely, then they can add a shoulder shrug, and that will help to get some anteversion of the scapula, and that joint should theoretically slide back into place. So this is a technique that does have a pretty high success rate, pretty short mean reduction time. So it makes it a pretty useful one for the athletic training setting. A useful clinician assisted technique is going to be the external rotation maneuver. In this case, the patient is lying supine and the clinician is going to be on the affected side, as you can see in the picture there. The clinician is holding at the wrist, and then in the picture, it looks almost like they're holding that more proximal forearm. However, I'd recommend grabbing more on the epicondyles of the humerus because you are going to have some longitudinal traction down on that humerus. So holding onto the epicondyles allows you to have that better traction pull of the humerus itself and not just gapping in that elbow joint. So the clinician is going to be holding on in those two areas, and then they'll pull that traction down while externally rotating the shoulder. If there is resistance or patient discomfort, then you want to pause and wait for those muscles to adjust and relax before you continue with that external rotation. Now, this technique does have a pretty decent success rate of 61% for a first attempt. However, it is a longer time to reduce. It takes about 5 to 10 minutes. Anecdotally, it's a gentle maneuver. So if you have a patient that with some neurovascular compromise, this might be a good one to consider trying. Obviously, you want the patient to be lying down, so it's a little bit dependent on, if you have a table right there at the field, what you can do here. And the last technique that I want to talk about for the glenohumeral joint is the spasso technique. I guess kind of last two. I have my own kind of modification. But the typical spasso technique, the patient is going to be lying supine. The primary clinician is holding on to those similar points right at the wrist and then up on those epicondyles. And you're still applying that same longitudinal traction, that same external rotation. In this case, it's useful to have an assistant there as well that can hold down at that clavicle and stabilize so that as you're pulling that traction and that external rotation, you're not just lifting that shoulder up off the table. You're able to stabilize that a little bit better. So that is the spasso technique. Now, the way that I was taught, I wasn't quite able to find exactly the technique for it, so take it with a grain of salt, I guess. But the way that I was taught is almost like a modification of the spasso technique where the patient is already standing. I talk about it a little bit. I have a video that I'll show you guys here of myself somewhat trying to perform it. But a lot of, I'll just play the video and we'll go from there. So that is how I was taught, and how I've done a majority of the shoulder reductions that I have gotten to work with. So one of the perks for this as well, the first time I saw it when I was in undergrad, the athletic trainer that I was with did it out in the middle of a baseball game. The patient had slid to third base, dislocated then. You couldn't really tell from the dugout from the sidelines. So the clinician went out, saw what was going on, was able to just very easily put it back in without a whole lot of people even knowing immediately. And then we went from there. So this one I think is pretty useful within our setting because you can do it anywhere using gravity um, for you, which is great. And you don't really need any sort of table or chair or anything to get the patient seated and comfortable. All right, and then I just included this for your reference. This is a table from one of the research articles that I found that mentions a lot of different techniques for the glenohumeral joint specifically, along with their success rates and their mean reduction times as well. So, and then a couple considerations for the post-reduction eval. You want to make sure you're checking the musculocutaneous nerve, the axillary nerve, brachial and radial arteries, make sure that everything is good there. And then a pearl, if you will, a trick of the practice. If the patient is wearing a Sully brace, which they likely will be if they're a repeat or a chronic dislocator, then you want to leave that Sully on for the reduction if you can, especially if you're doing it really quick on the sidelines, because it can actually assist you in pulling it back in. A lot of times, if you're just putting that traction and positioning, the body wants to reduce and wants to go back as long as there's not tissue in the way. So that'll almost help pull it back in. All right, next is the patellofemoral joint. I Therefore, if it is a lateral dislocation, if it is a medial or a superior, it's not recommended to attempt reduction. That usually has to be done operatively. So really, you only want to try it for the lateral. In this case, the knee is likely already in that flex position, as you can see in A of the picture there. And that's because that patella being pushed off to the side really limits that knee extension. So it won't let the patient extend it. So the clinician is going to take their hand in a C shape, and that's going to go on that lateral end of the patella. And you're going to apply pressure on that lateral side. And you're almost trying to do like a lift as well in order to get it up over the lateral femoral condyle as you're gently extending the knee as well. So usually that reduction is going to occur before the knee approaches full extension, and then go from there. So those are pretty easy. I have had one of these so far in my career. It went in easy. It was great. So all good stuff there. All right, so the interphalangeal joints. So these are going to be described based on the distal in relation to the proximal. So you have either dorsal or volar dislocations here. It's either going to be at the proximal or at the distal joint. The proximal dorsal is going to be more common. It's the least complicated. Whereas the proximal volar is going to have a lot more likelihood of soft tissue getting in the way and kind of blocking that reduction. Actually, I had one about last week that was proximal volar. So, and he did have some tissue that was getting in the way. So we gave it an attempt, couldn't quite get it all the way back in, ended up sending him. Thankfully, there was no fracture on that one, which is good, just more of that soft tissue in a position there. But yeah, so those are going to be a little bit more difficult. Then you also have lateral. With those, the special consideration is you're going to have some gross instability with collateral ligament damage. So you want to make sure with any of these interphalangeal joints that after you reduce it, in addition to checking neurovascular, you want to check that capillary refill. You want to make sure that they have full motion, full function, and that those collateral ligaments are still solid. So there are two common methods. There's the traction method and then the exaggeration method. So with the traction method, you're going to stabilize at the proximal. So one hand is going to stabilize there. And then the other hand is going to be applying axial traction and then while simultaneously pushing the bone in the direction opposite the dislocation. So you can kind of see on the images there, all like B, D, and F are all going to be that traction method. You have that traction, and then you're just going to kind of push the bone where you want it to go. With exaggeration, you're very similar. You're stabilizing at the proximal. You're going to have that longitudinal traction to it. Only in this case, you're exaggerating the dislocation. You're pushing it further out in order to get around the tissue so it can slide back into place. So for an example there, if you have a dorsal dislocation, then you're going to push it into a volar direction in order to get it down and around. And those images that I included on the PowerPoint are to show you a little bit more what's going on with the bone, from the bone perspective, so you can see exactly how you're trying to push it. A pearl for this would be that typically fractures are going to tend to rotate, whereas a dislocation is going to stay in one plane. So you might see like some spiral fractures occurring, or if there's like some chips or some fragments, that will give that finger a rotated appearance rather than just in line, but in a funky spot. Another pearl, ring should be removed if possible. If not possible, then try to get it off before the swelling starts, I guess, or get them somewhere quick. So yeah, that is important there. One last aspect on these. If it's a dorsal dislocation, so again, that's going to be if the distal is dorsal to the proximal. When those are put or reduced, that athlete can have them buddy taped, and as long as function is good, neurovascular is all good, they can return to play that same day. I would say that might be a little sport specific, depending on what they need to do in order to function for that sport, but typically buddy tape and it's going to be fine. However, they still want to get those images later just to be on the safe side, but they should be able to return. If it's a volar dislocation, they should not return that same day. You're going to want to put a posterior splint on, buddy tape, send for x-rays to make sure that that volar plate is okay. All right, so I think that's everything there. So next on to the humeral ulnar and proximal radial ulnar joint, or the elbow. This is one that it can be simple. So kind of the most common is going to be the posterior or posterior lateral dislocation. If there is an anterior dislocation, it's going to likely have a fracture of the olecranon. That would be one that you probably don't want to touch. Or it can be divergent, where the ulna is medial and the radius is lateral. That would be another one that you probably don't want to touch. However, that posterior dislocation, if you are seeing neurovascular compromise, or if it's going to be, for whatever reason, a delayed transport to a medical facility, if EMS is way too far out, or if you're in a rural area, then it's suggested to try one attempt. However, keep in mind that these dislocations are often pretty difficult, and they're often pretty painful. So if you don't have neurovascular compromise and you're right up the road from the hospital, might be in everyone's best interest just to send them. I had a posterior elbow dislocation couple years ago in ice hockey, and he was in a lot of pain. He didn't want anything really touching it or moving it. Hospital was 10 minutes up the road, so I didn't feel comfortable with an attempt, so we just sent that. And he had good neurovascular signs as well there. So it's useful to know how to do this for if you are getting that neurovascular compromise. But otherwise, it's probably a good idea to just go ahead and send. There can be some complications, fracture, in which case you might get some crepitus in there. Regular artery injury, definitely something you want to be checking for, and then entrapped median or ulnar nerve as well. In my case, I was also grateful that I just sent him because he did end up having an avulsion fracture fragment that was in that trochlear notch. So, and he actually wasn't really able to bend his or flex his arm at all. He was keeping it pretty straight, which I think would make sense with that fragment floating around in the trochlear notch. Um, but anyways, here's two techniques for reduction, just in case you are in a situation where you would need to attempt or want to attempt. One would be supine. So if the patient's already supine there, one hand stabilizing the forearm, and then one to apply that inline traction. I'm sorry, one to stabilize the forearm and apply the inline traction, while the other is holding at that distal humerus and applying pressure directly to that olecranon. So that's that top picture there, shows kind of the force and the angle we pulling. There's also the prone approach. If the patient is lying prone on a table and their elbow is flexed 90 degrees off the table, and you can see it's well supported there on the table. And once they're in that position, you want to correct any sort of medial or lateral translation of the ulna, make sure everything's lined up there. One hand applying that downward traction with supination, while the other is applying that pressure to the olecranon to get it back in. All right, so metacarpal phalangeal joints. These are so the dorsal dislocation is going to be the most common for these. It's typically going to happen secondary to a forceful hyperextension force. So if something hits off of that thumb and then pulls it dorsally there. And then for lesser metacarpal joints, they can dislocate either dorsal or volar. It's just less common. You don't see it as often. If it's simple, then the proximal phalanx is dorsal to the metacarpal head, and there's no soft tissue obstruction. Those should be fairly easy. It's worth probably an attempt at reduction. If it's complex, then that's when you have a buttonholing effect of the soft tissue. So as that lower image shows, that the bone is kind of poking through that soft tissue, and so it holds it there. So it's a lot harder to get through, and they're probably going to need the surgical intervention there. So really kind of the takeaway here, a dorsal dislocation of the first, or if it seems to be a simple dorsal of any of the lesser MCPs as well, it's probably worth an attempt. So in this case, it's ideal if you can hold the patient behind you. So if they have their arm kind of coming through underneath your arm and you're holding onto them like this, and that way they're back there, they're looking away, they can't like pull away or move. You've got it pretty well locked in and stabilized. And also it helps them sometimes if they don't have to look at it. In this case, you want to keep that joint in flexion and adduction, and that's going to help just relax all of those intrinsic muscles of the thenar eminence and the flexor pollicis longus, so everything stays nice and relaxed and goes pretty easy. So for this, you're just going to be applying distal pressure to that dorsal base of the proximal phalanx. You just want to push, not pull, and this is one of the few cases where you actually don't want to apply that longitudinal traction because you're increasing the chance of entrapping another structure in there. So this one's pretty easy. You just hold it and push. I had one of these back when I was in grad school and um, just started evaluating it and palpating. And as I was palpating, all of a sudden I felt it shift and go back in. So I guess like just the pressure of my palpation was enough of that pushing motion and it went back in place. So that one wasn't really even on purpose. I was just feeling what was going on and then it went in. So that was kind of wild. And then I had one other one actually kind of on myself. It was cold outside and I was working on outdoor practice and I reached behind me to grab the handle of my kit because I've got one with the handle and wheels, kind of like a suitcase. So I reached back to grab it and just that motion, I think my muscles were a bit overworked from doing a lot of like therapeutic modalities, a lot of active release stuff. And so that plus the cold weather, I think my muscles might have popped it almost in a bowler direction. So that was kind of wild. I just put it back in myself and kept going. So typically those bowler ones are going to be a lot more difficult. So it either must have just slid a little bit or I was just naturally grabbed it and put it in fast enough that it was fine. So also a caution there, make sure that you're taking care of yourself and your own thumbs while you're doing treatments. All right, this one is a big one, the femoroacetabular joint, your hip joint. This is an orthopedic emergency. So this needs to be reduced within 6 hours, is what some of the literature says. There's a little bit of disagreement on if that even matters, depending on the positioning, but it's a good rule of thumb. Within 6 hours, you need that hip to be reduced. Otherwise, the patient is likely to develop avascular necrosis of the hip. So it's a morbidity issue there. With your neurovascular assessment, you want to make sure you're paying attention to the sciatic nerve and the peroneal branch. Again, if you're having neurovascular issues, a single attempt is likely worth it because you're already on a time clock. So do not delay activating EMS or anything else. That should be first step. They need to go immediately regardless. But while you're sitting there waiting for EMS, a single attempt is likely worth it. Now you are likely to have mechanical block, buttonholing effect here. But again, having that or avoiding that avascular necrosis of the hip is probably worth trying. And then there's another acronym that is useful, DIFs, not really sure how to say it, but dislocated, internally rotated. So and fracture, externally rotated and shortened. So it's a good little mnemonic or it's a good little thing to have in your head when you're looking at the patient to determine if you think that there's a fracture in there. Now, concern for acetabular fracture shouldn't deter your attempt at reduction. However, concern for a femur fracture should. So, good thing to keep in mind there. All right, and there's two main techniques for this. There's the Whistler method, where the patient is supine, both knees are bent to 90 degrees. You have one hand on the affected knee underneath their affected leg, and then your arm acts as a fulcrum as you apply downward force on the affected lower leg. And that's that top picture there. The second is the Captain Morgan, pretty much same as the Captain Morgan rum stance. The patient is going to be supine, pelvis is stabilized with a strap or an assistant if you have someone there. The affected hip and knee are flexed to 90 degrees over your knee. So you have your foot right next to the patient with your knee behind their knee and stabilizing there. And then you're applying upward force to the affected hip by lifting with your calf and gently rotating the patient's lower leg in order to get that into that position for it to go back in. This one, with your post-reduction evaluation, you want to make sure you're paying attention to that sciatic nerve and peroneal nerve again, and then also for that femoral artery. You're going to check the femoral pulse, the dorsal pedal pulse, and then the posterior tibial pulse as well. Okay, so the tibiofemoral joint, um, this is that full knee dislocation. This is another orthopedic emergency, and it is potentially limb threatening. So very important. This one reduction has to occur within 8 hours. However, it's very possible to have other neurovascular injury when this occurs. So it really can be limb threatening if you miss a peroneal artery issue there. So they should be sent immediately regardless. Um, and this is one that you're not going to try to reduce. So I just wanted to include it for a little bit of extra information on it since it is so serious. However, I would not try to reduce this one. You're just falling on this one. So, and another important note here, all multiple ligament knee injuries should be evaluated and treated as a dislocation until proven otherwise, because so many of these spontaneously reduce. So they might dislocate, cause all that damage, spontaneously reduce, and you wouldn't necessarily consider it a tibiofemoral joint dislocation because you didn't see it while it was actively out of place. But that if it did dislocate and spontaneously reduce, there's likely to have a lot of damage in there that needs to be assessed immediately. So with this, you're going to be doing that continuous neurovascular assessment to make sure that that popliteal artery is okay. You're checking the dorsal pedal and posterior tibial pulses. You're checking motor and sensory testing of those tibial and peroneal nerves. These are all things you can be doing while you're waiting for EMS to arrive. And then the other important consideration here is making sure that the hospital that they are going to knows what the injury is because they need to be kept and observed overnight. This is huge as well. So don't just send them saying, oh, it's a knee injury. You want to make sure that they know what type of knee injury here. All right, and the last one here, this just a quick touch on metatarsophalangeal and interphalangeal joints of the toe. So the first MTP or the hallux is not going to be reducible if there's involvement of the sesamoid complex, or there can be some interposition or locking of the tendons there as well. You might have more success if you are attempting it immediately after it happened, but if not, then they're probably going to need a operative intervention, unfortunately. So the first one is going to be a little more complicated. The second through the fifth, give it a shot. You're going to use the same type of traction or exaggeration technique as with the fingers. And then any sort of interphalangeal joint of the toe, same type of techniques there. So give it a shot. And then I included this picture. I know it's a little bit different. I just thought it was interesting. I had this case when I was in grad school as well down at Georgia Southern, just free play basketball. Kid landed, and as you can see on that right foot, that whole middle section of the foot, all of those tarsals were dislocated. Amazingly, there were no fractures. It was just the whole thing shifted. So that was one I did not attempt a reduction. I just splinted and sent, but I thought it was a cool picture. So I included it for you guys. All right, a couple quick pearls here. And I mentioned most of these throughout, but most dislocations feel better with traction. So a lot of times just placing that traction on will reduce a lot of dislocations, especially if you're attempting it right after it occurs. One attempt is safe even for an inexperienced clinician. The damage has already been done. You're not likely to do a whole lot of extra damage with one attempt. So give it a shot because it can have a lot of benefits, depending on, especially if it's like a shoulder or a knee or a finger. Maybe not some of those other major ones, but also dislocations don't swell immediately, but fractures do. Obviously, there's always exceptions here, but that's a general rule of thumb. If it's immediately puffs up, there's a decent decent chance there's a fracture in there. If it's not swollen yet, obviously, as you're sitting there, and if you try an attempt, it might start to swell. Tissues will start to get aggravated and it will get there, but dislocations, it takes a few extra minutes. And then finally, neurovascular injuries occur during the dislocation, not the reduction attempts. So that just kind of goes along with, give it the attempt, because the best thing for that neurovascular compromise is the reduction of the joint. But you always want to make sure that you're documenting both the pre-reduction and the post-reduction status. Always check that, always document that. These are a couple useful articles that I included. So look at those at your leisure. And that is everything. Thanks, guys. Oh, and that's my references. Okay. We'll talk more in class.